Hello, everyone. I'm Carrie Thibodeau, the National Director of Programs and Public Policy at the Kidney Foundation of Canada. Welcome to today's webinar, Family Planning, Options, Lived Experiences, and Self-Care Strategies. Before we begin our webinar today, it's important to recognize the Indigenous land that we're on. Inspired by the 94 recommended calls to action made by the Truth and Reconciliation Commission of Canada, land acknowledgements are a necessary first step toward honoring the original occupants of a place. They also help Canadians to recognize and respect Indigenous peoples' inherent kinship beliefs when it comes to the land, especially since those beliefs were restricted for so long. I acknowledge with gratitude and respect that I'm joining this meeting today from Newmarket, which is the traditional territory of the Haudenosaunee, the Wendat, and the Anishinaabe peoples. If you know the territory from which you're joining today, please feel free to share it with us in the chat. And now I'll hand over to my colleague, Sadia Beg.
Hello, everyone. My name is Sadia Beg, and I'm the Programs Coordinator at the Kidney Foundation, and I'm situated in Ontario. It's my pleasure to welcome you all. The Kidney Foundation of Canada would like to thank our sponsors for the 2024 webinar series, Otsuka, GSK, Amgen, and Ensura. Their ongoing support allows us to come together to have broader, bolder, and braver conversations. The information shared in today's webinar is current as of today, June 20th, 2024. The information shared in this webinar is not intended as medical advice. The information you'll hear is general in nature and does not necessarily cover all circumstances. While we make every effort to be accurate, we recommend that you seek professional medical advice for your individual situation. And now I'd like to introduce to you our amazing moderator, Christina Hauerwen. Christina is a national and international award-winning investigative journalist who works at City News of Toronto. Most recently, she has been producing and hosting documentaries for City TV. Suddenly diagnosed with end-stage kidney disease in March 2018, she quickly had to learn how to navigate the world of nephrology. She started home peritoneal dialysis in September of that year and shared her experiences with her viewers. She received a living donor kidney transplant from her cousin in June of 2019 and has continued to share her experiences through the transplant process and the struggles with body image, and in the hopes of raising awareness of kidney disease, motivating more people to register as organ donors, and to encourage other patients to feel more comfortable and confident in their skin. Christina has worked with the Kidney Foundation over the last several years to raise awareness of kidney disease and organ donation. Now it's my pleasure to present Christina. Over to you.
Thank you, Sadia. To start the conversation, I'd like to introduce Dr. Amanda Cunningham. Now, Dr. Cunningham attended medical school at UBC and completed her internal medicine residency in Calgary before returning to Vancouver for the core nephrology program. She then undertook a clinical fellowship in both glomerular diseases and kidney disease in pregnancy at the University of Toronto prior to completing a Master of Health Science program and transplant fellowship at UBC. She's a practicing transplant nephrologist at Vancouver General Hospital, and her interests include women's health, patient education, and improving care for patients with recurrent glomerular disease following kidney transplantation. Over to you, Dr. Cunningham.
Great. Thank you so much for the introduction. So I'll be presenting today just a few minutes of sort of background on my approach to patients who are working through family planning in different stages of kidney disease. And then, like we said at the end in the Q&A section, you can hold any questions that you have about the sort of more scientific and medical parts for me for that time. Great. So my background is in general nephrology, and then I moved on to do some training that was more specific to the areas of GN and transplant, and then also did a fellowship in renal obstetrics, where I worked more closely with women who are and people of all kinds who are looking towards having a family, and just helping them plan what might be the opportune time for that, as well as looking after people who are pregnant in a specialized clinic in Toronto, and now bringing that back home to Vancouver, where we have a multidisciplinary clinic that looks after these patients called the Renal Obstetrics Clinic. So this is just a depiction of a figure from a research paper that was published that points out some of the different patient perspectives that people might have in mind when contemplating having a pregnancy or having a family, depending on who is affected with kidney disease. So things like social norms, wanting to become a parent, feelings of lack of control over what's been happening with their own kidney disease. It's very emotionally charged, worries about exacerbating their own disease and maybe accelerating the path to kidney failure or affecting transplant. Issues with the baby, fear of birth defects, things like that can all sort of play into this decision and make it even more challenging than it would be otherwise, with the extra added challenges that kidney disease brings. And these are some common questions that I hear from people who are coming for counseling appointments, or people who I encounter might be right after their transplant while they're still in hospital or in our clinic, in my current role, which is mostly as a transplant doctor. So people are interested to know how will the kidney disease affect having a pregnancy? Will the baby be healthy? Are there specific medication changes that need to be made? And then secondly, how will the pregnancy affect the course of their kidney disease and their journey? Will things happen faster? Will there be additional problems? What will happen to blood pressure? If they've already been transplanted, then what might happen to the transplant? And then also what to do timing wise. So how to pull all of those ideas together, how to best prepare. Is there anything that can be optimized, and how can we reduce risk? So to tackle those kind of one at a time, how will my kidney disease affect the pregnancy? And to answer that, miscarriages and infertility, they're not necessarily more frequent in people who have kidney disease, but we don't have a lot of information on this. And so that's what our group and other similar groups across Canada and internationally are trying to do, is gather more data and start to develop bigger, more kind of robust databases so that we can do research on people with kidney disease who are in this kind of situation. Another thing is we can talk a little bit more about timing of delivery. Full-term delivery is possible in all stages of kidney disease, but it does tend to be a little bit less common as the kidney disease progresses. And so it is a bit more often the situation that we find people delivering early. And then there is a higher maternal risk of having high blood pressure and preeclampsia, which is when the placenta develops in a bit less of a healthy way and can cause issues toward the end of pregnancy, including worsening protein in the urine and other issues. But there are ways to reduce the risk. So namely, we do give people aspirin during pregnancy to try and reduce the chances of developing this preeclampsia problem, which can really be quite an important issue to try to avoid. And then no higher incidence of birth defects due to CKD compared to the general population, which is an important takeaway as well. Things that are relevant in terms of fetal outcomes or what might happen to the baby is the higher likelihood of having a baby early, as I mentioned, so preterm. Babies that are smaller than expected for their gestational age or how many weeks they've been growing. And then also babies that might require NICU or special assistance. Often that is related to how early they're coming. And those risks can be mitigated if we are looking for those windows of opportunity where things are a little more stable with kidney disease, and also by being followed closely by the right team throughout pregnancy, which generally includes a high-risk obstetrician. Those can be doctors like maternal fetal medicine or MFM doctors, and then also a kidney doctor that generally would have some experience in following pregnant people with kidney issues. So that might be an obstetric nephrologist or someone with training like myself, or just someone in your local center who tends to take on these patients or have a little bit more comfort with managing these issues. To touch on the medication piece, which is a common question, common blood pressure pills that patients take, like Ramipril and Candesartan, have to be stopped prior to pregnancy. And then other treatments such as cholesterol pills, antibiotics like Septra that's used for transplant patients, and certain types of diabetes medications, like Forxiga, have to be discontinued. And as well for patients with transplants or glomerulonephritis, if they're on mycophenolate, Myfortic, MMF, that group of medications, they must be switched to azathioprine or Imuran at least 6 weeks before conception. So that's an important thing that we attend to for our patients who are on those pills. This is just a little diagram that demonstrates kind of what I was saying in terms of the medicines that are safe in pregnancy or not. But another important thing to draw your attention to is we do commonly get questions about breastfeeding safety of certain medicines as well. And some people have gotten the impression or been told directly by care providers that breastfeeding might be a problem or not be feasible for them. But on the correct medications, it's definitely something that we encourage in our patients, and we try to adjust your medication regimen so that that's something that that could be accessible and possible for you. Now moving to the second question, how will the pregnancy affect my kidney disease? So this is a bit of a busy graph. Again, this is from a scientific article that looked at what happens to people's trajectory with their kidney disease when they have a pregnancy. And so kind of the punchline here is you can see along the top of those little graphs, 3A, 3B, and 4 to 5, those are just the stages of kidney disease. So the little line kind of graph on the left-hand side is sort of early to moderate kidney disease. And then on the right-hand side is more severe with, GFRs approaching kind of that 15 to 30 range. And so what this really shows is you can see the gap between the two vertical red lines on each graph. That is the time of the pregnancy. And so you can kind of see that the blue line with the little yellow dots on it takes a jump from the space between the two red lines. And that represents that the GFR, or the kidney function, falls a bit more rapidly during that pregnancy time than it would if people didn't have a pregnancy. And that happens especially in people with more advanced kidney disease. So what does that really mean? It's possible that people might have to start dialysis or require a transplant a little sooner if they choose to have a pregnancy. And that can be anywhere around 1.5 years up to 5 years of accelerated kidney function loss if the pregnancy is happening kind of in the later stages nearer to kidney failure. This is relevant to transplant patients. So basically it just shows the black line that travels across the screen from left to right is patients without a pregnancy. And then the red line that takes sort of a downward dive shows post-pregnancy, what happens to the kidney function. This just shows that there may be a drop in kidney function for the first several years after having a pregnancy with a transplant, but they've done some studies to look at how the transplant is working and is it still functioning at 10 years out after a pregnancy. And the answer is it's the same as people who did not have a pregnancy. So it's not overall affecting the life of your transplant, but it may cause a temporary dip in the kidney function. And then when should I start trying to get pregnant? So this is something that we use as a bit of a model in our clinic from another sort of recent research initiative. We try to open the conversation with our patients where it's relevant or they've indicated that they want to have a family, and discuss what their plans are, perhaps refer them to a specialist in renal obstetrics if this is in a general kidney clinic, and then talk about risks, talk about what to do with medications, and discuss timing and steps that need to be taken. For instance, diabetes control may need to be improved, or they might need to start different blood pressure medications to help blood pressure be closer to target. And then as well, another thing to think about, which we'll touch on more throughout this, is the potential need for fertility referral. That's also something that we cover in these visits. So just to kind of summarize, in our preconception counseling appointments, which is when we see people who are interested in having a pregnancy, We talk about timing in the way of what are the individual person's preferences? Like, what size of family do you want? How many children? Do you have any already? What's your current health status? What's happening with your kidney disease? And then also age, which becomes important, particularly for women in planning all of this. We talk about risk to the mother or to the parent regarding their kidney function and health, hypertension and preeclampsia. And then also we talk about fetal risk or potential risks to the baby and what to do with medication management. How to modify the risk. So if you are going into a pregnancy with high blood pressure, lots of protein in the urine or fluctuating kidney function, those risk factors all influence the chance of having those outcomes, like problems with mom's health, problems with baby's health. So we do recommend talking to your doctor about your individual situation and how to optimize those beforehand. This represents sort of our, I guess, framework for talking to kidney patients in our clinic. We may make a recommendation here. The specific details are not as important, but just sort of the idea of the stoplight system. Like, we may make a recommendation to hold off for a little while. For instance, if you have lupus and it's active for 6 months, to try to settle things down prior to pregnancy. We may say, yellow light, like proceed with caution. Perhaps we've gotten things as good as they can be with blood pressure and kidney function, or we may not have too many worries and just say, go ahead now. And similarly for patients with transplant, one of the main things to know in the transplant situation is that we're looking to wait at least 1 year after a kidney transplant prior to clearing people to try to conceive or to try to have a baby. Optimally, they say that maybe waiting 3 years is better, but that's not practical often when we consider all those other things like age. And then just to briefly touch on women on dialysis, it may be a little more difficult to achieve pregnancy. So sometimes we will increase the intensity of the dialysis regimen. Patients on PD often need to switch to hemodialysis prior to conceiving. And then once pregnant, if you're staying on hemodialysis, it can require quite a lot of treatment, up to 36 hours per week, which can be easier for patients who are on home therapies. But if you're traveling to a dialysis center, obviously that can be something like 6 days per week for 6 hours per run, which is a lot of dialysis to do. And then transplant, again, we've touched on the waiting at least 1 year after. Patients often have a quick return of fertility and regular periods after transplant. Another key thing to consider is talking to your specialists about antibody response that you might develop if you have a pregnancy, which could potentially make it a little bit harder to match a future transplant down the road. And it's a little difficult for us to predict that. So how to put this all together and how to move forward. Talk about your family planning goals with your physicians. Like, we want to hear about them and help you plan specifically what might be the safest and best time for you to create your family. Having the right people involved, as I mentioned, the high-risk obstetrician and the nephrologist who's comfortable with these ideas and with looking after pregnant patients is key. There are lots of ways to have a family and to go about doing this. It may be sort of the conventional way, or it may require a little bit more medical care and specialized treatments. Your nephrologist can help work on the medication side as well as optimizing those other risk factors. And you may have access to a special clinic depending where you live, if you're in a more urban center like Vancouver or Toronto. And other specialists, if you have other conditions, like a cardiologist or rheumatologist can be involved as well. And then you may need access to fertility if you have a history of trouble conceiving or irregular periods. And then lastly, just wanted to touch on trying to take good care of ourselves during this time. It can be really challenging for patients who are in this process, and also partners, families, everyone else who's involved. So finding a support system is really crucial. Finding ways to take good care of yourself by eating well, exercising well, perhaps having professional help from a counselor or support group of some kind. And then just trying to kind of learn and educate yourself and ask questions so that you feel a bit more comfortable and and well in control of what the situation is, and that you have all your questions answered. And so that might look different ways for different people. Engaging in some kind of physical activity is great. Trying to make sure that, you know, you're taking whatever supplements and medications your doctor's advised, eating well, getting enough sleep, all these things can help feel a little bit more normal while going through a really stressful process. And then just a reminder here at the end that families come in all different shapes and sizes. That might be, you know, just you and a partner, it might be other extended family members, it might be pets, it might be ultimately having children. But people can sort of find fulfillment with that in lots of different ways. And we're always here and happy to talk about those things too. And then questions, I think we'll be mainly saving for the Q&A session at the end. Thank you, everybody.
Thank you, Dr. Cunningham. That was a really great presentation. I think for me, the biggest takeaway is that pregnancy and families are possible for most people living with CKD, even in dialysis and post-transplant. And you really do have to talk to all of your physicians and your medical team, and a lot of good things can happen. And I think that our next speaker will be able to elaborate a little bit on that. It's my pleasure to now introduce you to Manuel Escato. Manuel Escato is a 16-year kidney transplant recipient. He received a transplant from his mom all the way back in 2007 after nearly 2 years on dialysis. In February of 2022, he and his wife welcomed their first child, and just earlier this year, they welcomed their second. As a kidney transplant recipient, he's developed a passion for kidney and organ donation health education and supporting other patients to become partners in their own care. Over to you, Manuel.
Excellent. Thanks, Christina, for that introduction, Dr. Cunningham, for that excellent presentation, and just generally a thank you to the Kidney Foundation for hosting this sort of for this webinar. You know, as we and you'll hear about my experience, but certainly as families and, you know, people start planning for the families, these are really important educational tools that we need generally. But before I get started, I wanted to share that I am based in Edmonton, Alberta. I've been born and raised in Edmonton. Let's go Oilers tomorrow. But with that, really want to say that I respectfully acknowledge and acknowledge that I'm situated on Treaty 6 territory, which of course is traditional lands of the First Nations and Métis people of Canada. So before I get started, really it's a primer of my journey with kidney disease and with transplantation before we get into the family pieces, which will come during the fireside chat. And, you know, I'm 37 years old, soon to be 38 years old in a few weeks. And I've been a lifelong, my journey has really been lifelong in the medical system. I was born with something called posterior urethral valve, and I won't get too much into the technical jargon of what posterior urethral valve is, but essentially what it is, it's a blockage between your urethra and the bladder, so you're unable to pee. And in my circumstance, this was something that was developed while my mom was pregnant. Now, born in 86, and I know technology has come a long way and research has come a long way, but it's not something that had been screened at the time. It was screened for, and for that matter, as I share my story, you know, my parents came from El Salvador so they arrived in Canada in 1984. They had spent 4 years in Mexico, but they were born and raised in El Salvador. And one of the reasons that they had to leave El Salvador was because there was a civil war going on at the time. And the reason I bring that up when I share my story is really trying to situate kind of that context of why some of these, you know, perhaps gaps happen, why the screening didn't happen, or maybe it did happen, because at this point we really don't know. But, you know, my parents being quite new to Canada, you know, their English wasn't very strong. And as I reflect on them, you know, reflect with them, you know, many years later, you know, I've asked, like, you know, Mom, Dad, like, what happened? Like, what are these things that were happening? And they're like, we don't know. You know, we kind of just did what the doctors told us. But in any case, that's why I like to bring that piece up, because I really don't know many of the medical parts that happened when I was young. But I was born, and soon after I was born, you know, within weeks, I was diagnosed officially with posterior urethral valve, and that really started my journey into the medical system. As I said, grew up in the hospital. My dad often jokes whenever we drive to the University of Alberta Hospital that was my second home. I spent so much time, like long-term stays in the hospital, trying to fix this issue. posterior urethral valve. And that, for those who don't know, is something that really impacts your bladder more. Again, I won't go into all the details, but growing up, I was constant on medication. I had major surgeries trying to fix this issue. And at the age of 12, we thought it was fixed. You know, I went in and it was all good. And, you know, Manuel gets to be, I go like this, like my quotes for people, if you can't see me, like a normal boy, because I didn't have to take all that medication and all the very uncomfortable procedures that I had to do. I didn't have to do that anymore. Out of my soon to be 38 years, I've been on medication for 34 of those 38 years. So I was at that age gap of about 12 where I really didn't have to take much medication. Life was good, went to school, you know, everything's looking good. Started my first year at university at the age of 19, and it was during my semester, my first semester, that I just all of a sudden didn't feel good. One symptom, blurry vision. Within 2 weeks, I was in emergency. And in emergency at the hospital, they say, you know, I did a couple of tests, and the doctor comes out and says, you know, your kidneys have failed. You need to start dialysis like right now, and you're eventually gonna need a transplant. And I didn't know any of those words. Like say, you know, situate yourself as like a 19-year-old, you know, you're sitting there in the hospital, your mom's by your side, and they're saying transplant, organ failure, dialysis. Like, what are you talking about, sort of thing, is the way I remember feeling. And, you know, soon enough, I was very much onboarded into what that process meant. I started dialysis within 24 hours just because of my creatinine, how substantially high it was, to the point where had I not gone to the hospital, you know, that day or soon after, like I probably wouldn't have lasted more than a couple more days. I spent 21 months, so just under 2 years, on dialysis, and I was the very fortunate recipient of a living kidney donor from my mom. From the very beginning, my mom's the one who said, "It's going to be me who donates. I am going to donate." But you know, throughout this, as I experienced all these, you know, bladder related issues with your, you know, your urethra, and probably too much information, but I didn't like pee like a normal, you know, individual would pee until I was about 8 or 9 years old. And that always struck me as I grew up and got older. And then, you know, I'm married now, but even before I was married, you know, the thought of having children worried me, in the sense that I didn't know if I was going to be able to or not. And those are some concerns I'll get into in the fireside chat, but we'll end my story by sharing that we went through the IVF process, my wife and I, on 2 separate occasions, and very happy to say that I have 2 little ones, as the introduction said, a 2-year-old and a 4-month-old, soon to be 4-month-old. But the journey is difficult, and I think that's why we're here to talk about this stuff. It's not always easy, but as long as there's resources and people you can connect to, it makes the journey a little bit better. So happy to share my experience a little bit more in depth in the fireside chat.
Thank you so much, Manuel. And I really do want to hear about your kiddos, and you didn't tell us their names. Do you mind sharing?
No, of course. Yeah. So the 2-year-old, his name is Camilo, and the soon to be 4-month-old is Santiago.
Those are wonderful names. I love it. I love it. And we're going to hear much more from you during our fireside chat, as you said. Our second panelist is Susanna Dapil. And I hope that I'm saying that correctly, Susanna. I'm sorry, I should have checked first.
No, you said it perfectly.
Awesome. Okay, great. After spending 4.5 years on dialysis, Susanna received a kidney in 2009 from a donor that she refers to as her angel donor. This past January marked her 15-year transplant anniversary. That's worth an applause. Susanna is very passionate about organ donation and a dedicated advocate for others waiting for the gift of life. After her transplant, Susanna began volunteering for the Kidney Foundation as a way to give back. She's now the manager of the Fund Development and Community Relations in Saskatoon, Saskatchewan. Susanna has been with the Kidney Foundation for 9 years and continues to contribute to the cause she cares so deeply about. Let's hear from Susanna.
Thanks so much, Christina. I appreciate being here today. I think for me, if I can educate or give a little bit of help to anyone, lead them direction, you know, I don't have the ending of the story that I wanted, but if I can help someone else, that would be wonderful. So usually if I'm talking about my kidney, I say I'm Susanna and I'm a kidney transplant recipient. But also this, I'm going to add on to my title. I am Susanna and I am childless, not by choice. And that is a term I learned after going through all this. There was a term called childless not by choice and then childless by choice. Because people always asked me if people are like, do you have kids? And I said no, but people are curious, people want to know, like, is it by choice? Is it not by choice? And I've learned these terms as I've gone through this journey of mine. A little backstory of my kidney journey. I was diagnosed with lupus in high school in grade 12. Lupus is an autoimmune disorder that can attack your joints, your organs. At first, it was just my joints, and then over the years, it kind of started attacking my kidneys. I was being monitored, and then one day I got really sick, and I was sent. Originally, I'm from Edmonton, just like Manuel, but now I live here in Saskatoon. But I was sent to Emerge, and I started emergency dialysis, and ended me in the hospital for 30 days. I got kidney function back. I thought I was cured. 4 months later, I got violently sick again and I started dialysis. At 21, I thought I was, invincible. I was like, okay, 3 months more, like 1 month top on dialysis. And that 1 month on dialysis lasted me 4.5 years on dialysis. I have an extremely small family. I did not, well, back in the day, I got my transplant in 2009. So during that 4 years on dialysis, I didn't have a voice. I just kind of went through the motions of being on dialysis, being sick, getting through day to day. But now I've learned to be an advocate for myself. So I received the gift of life on January 31st, 2009. And during that whole time and being focused on being sick, and while your friends and family are traveling, going to university and making memories in their 20s, I'm in the hospital. I didn't think at that time anyone would want to. Everyone was dating and getting married. I was like, who's going to marry me, a sick girl? Ever since I was a little girl, I wanted to be married and I wanted to have kids. My mom was a single mom and she had me, and I was like, I want that. I want to have my own little girl to myself, And I always thought that would be the case. And then, transplant happened. And then, when I was 29, I met my future husband. And I was like, okay, after I transplant, things are looking up. I potentially am going to get married. I am, and then during in 2014, before we were married, my doctor asked me, I moved to Saskatoon, and one of my new nephrologists asked me, he said, are you going to get pregnant? And that was the first time out of my transplant journey somebody's ever talked to me about that. I never thought that was an option. Nobody ever talked to me about it. It kind of gave me hope. But my husband and I weren't married. I was always like, hey, let's do things in order. I want to get married. I want to have a child. I just said, we're not there yet. We just moved to Saskatoon. We're still dating. But he's like, he mentioned this word and he's like, you're in your prime of your transplant. And that was the first time I ever heard of that. And I didn't know what that meant. But it was clarity that, again, kidney disease, there's treatment options, and transplant is one of them. A transplant is not a cure, it is a treatment. It's the better of the two, but it is still a difficult journey. And so that kind of took place there. And, we got married in 2016. That summer, we decided, let's try this. I was going to switch my medications. But then I got the call. I did blood work and I got the call that I had a virus. And some may know it or are familiar with it, but it's called the BK virus. And so I had to switch my medications that weren't pregnancy safe. So I had to, and this virus was not going away. So then we decided, my husband and I, to look into adoption, either locally or internationally. And there was a lot of roadblocks, a lot more roadblocks than I thought. And people think it's an easy path, and it's not. You know, I thought, okay, I'm from Edmonton, we can adopt from another province. You can't, you know, unless it's a private adoption. You have to adopt within your province. So then we went that route, and I thought maybe we could foster to adopt. And in Saskatchewan, you can't. You either foster or you sign up for adoption. And the adoption wait, because my husband and I really wanted to experience the whole, we wanted an infant, you know, maybe infant to 2, but the wait time for adoption was up to 8 years. And that blew my mind, because I was like, there's so many children that are needing homes. We talked to another family that did international adoption, and they spent over $100,000 adopting from the US. We talked to, I felt like it was roadblock after roadblock, and it deflated us. Every time we were hopeful or we talked to someone new, you know, I think we just got home and just weight was just put on us every time we got home from meeting someone or talking to someone. And when was it going to be our turn, you know? And then we decided at that time, we met with our surrogacy in Saskatoon. And at that time, it sounded that it was the easiest option. It sounds like when people hear of IVF and surrogacy, that it's difficult, but at that time, with our options running out, it was the easy version for us. Like, this is the easiest way. And again, it was difficult. You know, COVID happened. You know, we started our journey in 2018, and our surrogate, it went to 2022. So, you know, first we had to do all of our IVF. So I did the IVF. I had 10 eggs retrieved. Out of that, 1 viable embryo came out of that. I had 1 chance, you know, and it was tough. And then we did that. And then our next chapter was finding a surrogate. And I'm like, how the heck do you do that? You know? And it was at that time when people were more vocal on social media, finding a kidney, and, you know, people were out there telling their stories of what they needed, and people were coming out and helping. And my husband and I are very quiet that way. We're very private, but we decided to put our story out there on social media. We had to start it with, this is not a pregnancy announcement, because it was a picture of my husband and I holding up our 1 embryo little picture. It was at Christmas time. So we had to really say, this is not a pregnancy announcement. Don't congratulate us. You know, this is what we're looking for. And it took about a year. We had a surrogate lined up, but she backed out, which is totally fine. It's like the kidney journey I always relate it to. It was devastating, but again, you know, things happen for a reason. And then through a friend of a friend, somebody from Ontario said, hey, I want to be a surrogate. And I was like, this is crazy, you know? So we did all this workup in, I think in 2018 or 2020, over COVID, 2020 to 2022. COVID stalled a lot. We never met, but we did video chats with her and her husband. She just wanted to do it for a lot of hard work. It was a lot of personal questions that had to be asked. With lawyer stuff, we had to decide if we had to, before everything happened, we had to pick our godparents without even proceeding with the transfer yet. We had to say, okay, if this happens, who's going to take care of what? We had to make sure just everything in the lawyer agreements had to be up and running. Questions that we wouldn't even think about or talk about until the baby was born, where the baby was going to be born, when we would come, when we would take the baby away. It was just, and it was my husband and my parts of the embryo, it was, but yeah, it was just a learning curve and a lot to learn. And then we flew her out here. It was the closest thing I could get to pregnancy. It was amazing. We bonded, we crafted, we had dinners together. My husband had to give, I'm not good with needles, but my husband had to give her an injection. So we were just all on the bed and he just, and once the transfer happened, she did everything that I wanted to do. Like we did warm foods, nothing hot, nothing cold. I said, even after transfer, I'm like, it's going to sound silly, but can you just put your feet up in the air for like an hour so it just stays up? I don't know. But I was like, Annie, and she was just willing. So here she is at my house on my bed, like with her feet up on the, and 3 days later, I got the call and the nurse called. And as soon as she phoned, it didn't take. And I just handed the phone to my husband because it was just, what else? Like, it was the end. We've discussed it after all that time. And our journey was done because my husband and I had many talks, like, when is this journey going to be done for us? And so, yeah, when that nurse called, I just knew right away it didn't take. And yeah, so here I am, but my story is not a reflection on anybody else's. I know many people in the kidney transplant community that have beautiful children. Manuel, I work with other people who have two girls, another kid. So, I feel like I'm the minority in this journey. So I don't want this to be a negative in any way. I just hope my journey and my story can help other people be more advocates for themselves. So please do not get discouraged from my story. That's the last thing I want you to take from this. Sorry, I hope I didn't go over time.
No, not at all. Susanna, thank you so much for sharing that. That must have been like, it's really hard. I don't even want to say heartfelt, but like it was very brave of you to share that. And I really appreciate that as a woman of a certain age I have shared many of those experiences as you have post-transplant. And I think it's important to hear because yes, I love that there are so many happy post-transplant babies and families that are born, and many families that are born, through with pregnancies during dialysis and later stages CKD. But I think it's important to acknowledge that despite best efforts, sometimes it doesn't work out. And I really appreciate you sharing the childless but not by choice, because going forward, I think I'm going to be using that moniker. And yeah, it really touched me. And I hope that there are other people that are, listening to this webinar that are getting something from this. One thing that I thought was very interesting is you said, here you are like 6 years in, I believe, before somebody actually sat down and said, what are your plans? And because of my age and because of how, where I am in life, and where we were in life when we found out that I was sick, and then when we found out, when I got my transplant, we knew we were supposed to wait, but we were like, you know what? Everything's good 3 months in, 4 months in, let's start trying now. We weren't getting like additional medical help, that was fine. And I was so very fortunate because I'm a reporter, and I happened to be doing a story with Dr. Michelle Hladinich, who's at Sunnybrook, and she, very much like Dr. Cunningham, specializes in, or she has a specialty in pregnancy and CKD and transplant and dialysis and all that stuff. And I happened to interview her, and she said, well, you can't be trying until you're a year in. And I was like, yeah, but we're just going to start now. Like, probably not going to get pregnant right away. And then she's like, no. And she was, God bless her, because like my 1 year mark for my 1 year anniversary, she wrote it in and she got me in like day 366. I had an appointment with her, right? Like,
That's
it was that
amazing.
great. But, I think that it's something that maybe transplant nephrologists have to really think about is, this has to be really well communicated to patients and their partners if they have one, because we didn't know that Myfortic could cause so many heart defects and ear defects and all of these other problems. And, we had to wait to be on the azathioprine, or however you pronounce it. I'm sorry. I'm sure all the medical people are like, I can spell it. I can spell it. But, it wasn't top of mind. And because when you are going through a transplant and you're going through all of these things, if things aren't really well communicated, and that's like almost like a special chapter in their journey, it's really easy, I think at least, for it to be overlooked. Or, you know, I'm learning how to take 12 different types of medications and how often I should be doing my blood pressure and stuff like that at home. And you throw in like a one-liner, that I'm not going to retain that information. Like it really has to be hammered in. And I know that maybe I'm being a little bit biased here because I'm a woman of a certain age, but you know, Manuel, I know you were much younger when, you know, you went through your transplant, and, you know, I'm sure that fertility issues and family planning might not have been top of mind for, I'm guessing you were like 21, just trying to do quick math here. Yes or no? I'm not the greatest. at math.
When I got my transplant, I was
Yeah.
21. Yeah.
Yeah. Okay. Okay.
Yeah.
Journalists aren't known for math, right? So
No, very, no,
trying
very
to
good,
trying to
very
add
good.
things up quickly. But what were some of the considerations and challenges that you encountered when you and your wife decided, hey, let's start making our family?
Yeah, you know, that's a really good question, and I love your preamble about, you know, something perhaps not something I was considering. I think that's true for many people. I think that's true for many 21-year-olds that aren't considering
Right.
long term what their, you know, future family life is going to be. I will say I was perhaps a bit different in that not that I was saying, hey, I'm 21, I'm ready to have a family, not at all. But at least the concerns around whether that was going to be possible was something that was always top of mind. Because of just the nature of my original diagnosis of posterior urethral valve and some things that can cause, fertility sort of being one of them, but not really. Like some of the things I've done just as a self-coping type of mechanism is going out there and reading like more academic literature papers of what, you know, what science is telling us. And like from a very young age, those are sort of the pieces that I was already proactively doing. But in terms, and that's good and bad because it either gives you reassurance or it causes more doubt. So in terms of considerations, one of the things that I found super helpful was just being as open and honest as I could with my partner at the time, who is now my wife, and then also with my doctors. I brought this up with my doctors, like not an in-depth conversation, but just being like, hey, so this is what I was diagnosed with. You know, I'm in kidney failure now. Like, what does that mean for planning a family? Or what does that mean for having kids in the future? So that was like about the level of extent of conversation I had, but it was something that I still proactively, you know, went out there and was asking. And, you know, maybe because I was younger, or maybe because, you know, the science isn't really there as to whether, you know, posterior urethral valve causes fertility issues or not. I kind of got the answers of like, oh, like, no, like you'll be fine, right? Without anything else. But I recall, so I've had a couple of nephrologists, as you know, people retire and move on, but I talked to all of them. I asked all of them, talked to my family doctor. So at least I was there trying to find some answers, which I thought was helpful in trying to guide my state of mind. One thing that I did very early on, so I'll say this, so I've known my wife for forever, since we were kids. We started dating at 23. We started dating, we're like, yeah, we're gonna get married. Like it was kind of what one of those. So I will say, even despite that, like very early on, I remember having like that uncomfortable conversation with her. You know, maybe like a year into it. It's not something that like is normally, I would say, probably not done, that you're, you know, you're with somebody and you're like, hey, we're, you know, thinking about having babies. But I remember having that conversation with her because I wanted her to know that this was a concern of mine. And really the conversation was like, hey, like, this is what I was diagnosed with. I don't know if I'm able to have kids or not. And not that we were planning at all at having kids at that age. We would have been 24, 25, but just building that communication, building that, you know, okay, this is where we are, and then saying, okay, now we'll deal with it once we get to that stage. So I found that to be super helpful. A couple of other challenges, and, you know, I brought up my parents during my little introduction. You know, we come from a Hispanic background, and I know this isn't just for Hispanic communities, but I know there's, you know, kind of certain pressures to have families that, you know, and especially families at a very young age. Like my siblings had kids very young, and my wife's end, they had siblings very young. You know, we were approaching 30, or now we're getting, you know, close to 30, and then that's where it starts, right? Like, when are you gonna have kids? When are you gonna have kids? And that constant pressure. What was a little difficult, I think one of the things that we did, and upon reflection, we might have done differently, is we didn't talk to anybody about our situation. like as it became obvious that we would have to go through fertility treatment and ultimately my wife, you know, through us, but my wife through IVF, we kept that all to ourselves, which was both good and bad, in that we were able to be in our little bubble, but also we didn't have that support. You know, Susanna, you talked about that support and how sometimes just sharing that from a like maybe a mental health perspective is so beneficial. But we had those pressures, we had those outside pressures, and we're trying to navigate our own situation. But yeah, like those are some of the challenges. And then just I'll add very briefly, not knowing whether my children as well were going to be born with posterior urethral valve. So from what I understand, it's not something genetic, right? It's not something that they were automatically going to get, but that was also one of my very strong concerns about having children is, you know, I don't want, you know, what if they go through what I did? You know, what if they're, you know, hospital babies, and what if they live their whole lives in the hospital? And what if they need a transplant eventually? But again, it's just about having that open communication and talking about this with your doctors, with your partner, and eventually with your family, which I wish I would have done in retrospect, but I didn't. Maybe I'll pause there and see if anybody has anything else to add.
Well, one thing I want to bring up is, you know, I'm hearing from 3 patients here, you know, who have been through fertility treatments and, you know, through that practice in order to try or to have ultimately their families. But Dr. Cunningham, is this something that all CKD patients ultimately should expect, that they will have to go to a fertility doctor? And, you know, when should a patient start thinking about, do we need some additional assistance aside from, you know, our regular physicians, nephrologists, transplant nephrologists, et cetera, et cetera, et cetera?
Yeah, that's something that we talk about pretty commonly in our practice, but it's definitely not something to expect necessarily. Like, we do have patients that have pregnancies or have families without any fertility assistance, but I would say it's you know, a layer of additional difficulty with the CKD kind of time course, because there may be periods of time where it's not medically feasible or advisable to have a pregnancy. So as Susanna was talking about, like maybe you have a viral complication with your transplant, or maybe you have an episode of rejection, or you know, maybe things are not going super well on dialysis and you have to switch. And so there may be like several years that are sort of your more fertile years where you can't actually conceive because it's not recommended. It would cause lots of risks for you and for baby. And so because of that fact, it often will get delayed or pushed forward to a point where people's natural fertility starts to decline, which for women is like somewhere around 35, especially after sort of 37 to 38, that it's more sharply declining. And so it is something that then becomes a lot more relevant. So we encourage people to, especially if they're in that age category, or if they're younger than that, like less than 35, and they've been trying for a year and not had a pregnancy. This is like with, you know, sort of under medical supervision. If they've not had a pregnancy, we would send them to fertility, or if they're over 35 and they've been trying for 6 months with no success. And then other risk factors that might sort of come into play that make me particularly think about fertility challenges might be people with lupus or other glomerular disease if they've been treated with cyclophosphamide. That will reduce fertility, especially if they've received a large dose. So those are sort of some considerations in terms of my personal feelings about like when somebody should have a consult with a fertility doctor.
So kind of put it into your plan.
Yeah, I would say like
like a contingency plan at least.
If you're at a stage in your relationship where you're wanting to have children and you're 25 and you have mild CKD, then that's great. You know, that doesn't really apply to a whole lot of people, but if it does apply to you and everything's kind of aligning, then like that is probably your window, because you're not really very likely to need fertility assistance. Your kidney disease is not very severe at that time. And if your relationship, finances, everything to do with life is sort of ready for family, then great. But it does get yeah, it does get definitely more tricky to figure that out if you're older and or your kidney disease is worse and or you don't have a partner yet, or you're trying to figure out if you might want to do this independently. All those kinds of things can be complicating. Yeah.
What advice would you give to anybody, any patient that's coming to you saying, you know, I'm at stage 4? What type of like quick tips would you offer to people that are looking to start a family at various stages? And I know you addressed this somewhat in your presentation. Actually, you broke it down pretty well, but just a recap, if you don't mind, doctor.
Yeah, I mean that can be a tough time to come. It's good, but it's also tough if you're sort of in that, like my GFR is maybe 20 or something along those lines. Because it's good for us to have as much lead time as possible to plan with you. We want people to come and have conversations with us, even if they're not 100% ready to start trying yet, because that gives us more years or months to try and optimize the things that I was talking about with regard to like blood pressure, proteinuria, kidney function, things along those lines. But if you're coming with that sort of, GFR 20 type range, we will have an hour-long conversation about what to do. Because if you have a pregnancy right now, there's a non-zero chance that you wind up on dialysis during the pregnancy, like maybe about 50%, which is a big deal, right? Like the transition to dialysis is huge, and trying to imagine doing that while pregnant, especially if it's a first pregnancy and there's like lots of anxieties and difficulties that come with that anyway, trying to also start hemodialysis and maybe require a lot of hemodialysis, like up to 36 hours a week, is really onerous. So we would talk about that option. It has some benefits in terms of starting a family earlier and perhaps less likely to need fertility if you're in your 30s, because you would be, timing the pregnancy a little sooner. The other option would be waiting until transplant. And so if you have a living donor, you might be able to achieve that relatively quickly. We probably wouldn't do the transplant with a GFR of 20, but we may do it between that 10 to 15 range, which may require, waiting another year while you get your donor together as your kidney function declines, doing the transplant, and then waiting your minimum 1 year after the transplant to try to conceive. So taken into all of that, we would be talking about like, okay, what size of family do you want to have? What age are you starting at? If you're late 20s, early 30s, waiting until post-transplant definitely makes a lot of sense. If you're late 30s, early 40s, you probably don't have the time to wait until transplant and the 1 year following. Or if you do, there's a significant chance you'd have trouble conceiving. So it's really kind of like this soup of all these different factors and considerations. And we really try and personalize it because everybody's unique, and what kind of family they're looking for at what point in time, personal life factors, financial, partnership, etc. Like it all is going to play into the ultimate decision and recommendation from our side.
One thing that is brought up quite a bit is considering adoption, and it's very different in every province. Susanna, you were talking about how you can't foster to adopt in Saskatchewan, but in Ontario, that's a very common practice. Same thing in Alberta, I believe, anyways. I am from Ontario and I'm coming to you from Toronto. You went through this, Susanna, and I know you did not get the outcome that you were looking for. But for people that are participating in this, what type of financial implications, if you don't mind sharing, should they be considering when they're looking at these different routes, at least from your perspective?
Yeah, when we were looking at adoption, of course, local adoption, it's free, but international adoption, my 2 cousins were adopted from Romania back in the day. And I said, if we ever do that, I would love to do that. But they've closed adoption in Romania. And looking at the cost, like I talked to a family that adopted somebody, a little child in the US. And we talked to the ministry too here, and there was no guarantee. You could go with somebody, a mother who, is adopting their child. They could just back out at any time, and you could have paid all this money and you're just taking a huge chance. And the costs were astronomical. It was up to, I think this family that we met in Saskatoon um, paid over $100,000. But then we got to meet her beautiful little girl, and it was just like, you can't put a price on that. But it's sticker shocking, which is when you're talking about a child, it's just, it's really hard to grasp and even talk about a price. When we went through the IVF, we really had to sit down and talk about our finances. We had to make the decision, how many rounds are we willing to go? Dr. Cunningham mentioned with having lupus, one of the treatments is called cyclophosphamide. I did that when I was 17, when I was first diagnosed. I did 2 different rounds. Being so young and then having a single mom, they did ask if we wanted to freeze my eggs. But being young, not having, my mom was just on my health, being single mom, didn't have the money to do that, but it didn't even cross our mind. And I know that it bothered my mom later on, knowing what we went through. Um, and so, it's just tricky. But going through, last night I was kind of going through what we paid, and I'm very open about this because it can help. But making that decision with your partner, your spouse, talking about what you're prepared to do ahead of time. We discussed 1 IVF round. Having that in place kind of helps you, because you could just keep going. It's like, I don't gamble, but I can assume when you're gambling, you're like, oh, I was so close, and you do it again. So, IVF, my journey with IVF was just over 8,000. And then when we got our surrogate, it didn't go all the way. It would have cost, I don't know how much it would cost throughout the 9 months and post care and everything. But with the virtual telephone, medications, the frozen embryo transfer, all of that, that was about 5,000. Lawyer fees were about 4,000. And then paying the surrogate, mileage and other, all of that, that was about 3,000. And that was just at the beginning. So everything is just over $17,000. And that was just our one chance. So, yeah.
And sorry.
Oh, sorry. And my husband's family is from Ontario, and they, one of our friends went through the IVF, and they said, well, don't you get that your first round covered? And I said, no. And they got their first round covered. So again, know where you're situated, know your options, because that was an option in Saskatchewan. I don't know about other provinces, but I know in Ontario, from what I understand, I guess your first round of IVF is covered or majority covered, that kind of thing. But making sure that relationship with your IVF coordinator and your transplant are on the same page too with medications.
Right. So in Ontario, you do get your first round of IVF covered. It does not cover your medications. And my understanding is that most places will not jump you right to IVF. You'll likely go through a couple of rounds of IUI first, which is not covered. Right.
Okay.
So, but again, it's covered, but it's covered like $3,000-4,000. If you don't have a good health plan, you could probably anticipate, up to $6,000, up to $10,000 more in additional costs, particularly if you want to do genetic testing.
Yes.
Which, for a lot of people that are involved in the kidney world, seems like something that a lot of people would also, at least consider, but by no means have to do it. I always thought of it as, if my parents had genetic tested, me, I wouldn't be here right now, because my kidney failure is Alport syndrome, which is a genetic disorder. There are a couple of misnomers and misconceptions that are out there about women and various stages of CKD. And you touched on some of them, Dr. Cunningham, with, yes, a full-term pregnancy is possible, but it depends on the stages, depends on, where you are in your kidney disease journey. But are there any other sort of myths that, should be addressed or dispelled? Like, do all CKD patients have to deliver by C-section? You already addressed, I think, whether or not breastfeeding is possible, but are there any other myths that you think should be addressed?
Yeah, I think there are a lot of misconceptions. I think, first of all, the biggest one that we contend with is people being told or maybe hearing the message at some point along the way that either they can't become pregnant or that they shouldn't become pregnant. And so we encounter that sometimes in dialysis patients or transplant patients who think that they are not fertile at all. Or that they may not understand that with transplantation, their fertility will probably be restored quite quickly. So there's a couple of reasons for really good contraception, especially in that first year post-transplant. And yeah, just sort of encouraging people to bring this up, doctors to bring it up as a conversation, and also patients to advocate for themselves, just in the way that sometimes nephrologists might say, oh, your numbers, make me a little nervous and I'm not too sure if pregnancy is a good idea, but they may not necessarily work with many patients who are having families or wanting to have pregnancies. And so definitely having assessments by like the high risk obstetrics and then a nephrologist who's more comfortable with these preconception planning visits and ideas is important, because a lot of the time it is possible, and it's more about finding the window of opportune time, like I talked about. It does not have to be a C-section delivery, so that's kind of another good thing to touch on. It is usually for patients who have not had a transplant and are on dialysis. There's no reason why they would require a C-section, but for patients with transplant, it's usually like a provider-based decision, depending on the OB that you have and some various medical details around your situation and your transplant itself. They may make the decision that they'd like to schedule a C-section. They also often conference with the urologist or whichever surgeon did the transplant surgery, just so that they can understand really well like the anatomy there and make sure that when they're making an incision for a C-section that they're not running into anything unexpected because the transplant's in a similar area.
How would you suggest, and I don't know if Susanna or Emmanuel want to jump in after Dr. Cunningham speaks on this, but how would you suggest, communicating your priorities in terms of family planning to your transplant nephrologist or to your nephrologist? Like, is there an easy way that, people could say, I know I'm at stage 4, I know I'm on dialysis, but this is something that's important to me and I want to make sure that this can still happen. Like, is there an easy way to do this?
Yeah, I mean, I think you guys have all phrased it really well today. I mean, generally, I don't know how everyone, else conducts their visits, but usually when I have like a follow-up appointment, say in transplant clinic, there's usually a little time at the end to say, like, do you have any questions? And people might ask me about a trip they're planning to go on, or can they go to India for 3 weeks, or can they start eating out at restaurants if they're like a fresh transplant, or whatever sort of miscellaneous questions they might have. And I would just say maybe it seems like a bit taboo or not directly medically related to some people, but we really care about our patients' lives and we want to know like where people are at with this, because we know it's such an important part. It's not just like, how is your transplant function? It's like, how is your transplant function, and are we helping with getting you back to living your life in the way that you want to, whether that be going to work, traveling, having a family. So we want to help make those things happen, and we want to do it safely so we can protect your kidney and have it work for many, many years. So yeah, I think it's just as simple as that. If there's a moment for questions after we've kind of run through labs and blood pressure and all that stuff, standard stuff, just saying like, hey, just wanted to mention I'm interested in having a family at some point. I don't have a partner right now, but I'm in my early 30s and I just sort of wanted to get your take on things. Is there anything I should be thinking about? Should I freeze my eggs? Like those sorts of questions would all be sort of very like standard good questions to ask. And sometimes we might say, why don't we book a separate appointment to talk about it? Or why don't we refer you to our renal obstetric clinic and you can have like an hour-long chat and have time to go through all of those different factors.
Manuel, how did you address it with your doctor?
Yeah, so I mean, mine was a little bit more different circumstance in that I was post-transplant. My kidney was doing quite well, but to Dr. Cunningham's point, like I think you really hit it when you said, you care about your patient lives. And, speaking from my perspective, that is the one piece that I've always valued from the different nephrologists that I've had is I get the sense that they care about me. It's more than the numbers, it's more than blood work, it's more than your urine results. It's, how is school at the various stages of my life, how is university going? Okay, now how's the work going? Okay, now how's the family doing? That sort of thing. And at least for me, it was more of a comfort piece that because I knew they cared and because they did genuinely have interests in knowing me outside of these numbers. For me, it was quite simple. I explained. It was a couple of conversations that happened. But the first one, I just said, hey, like my wife and I are thinking about having a child, having a child. I know we're on medication, different types of immunosuppressants. I know we're on medication, and I've been told, or I've read, however I phrased it, that certain pieces that I might need to discontinue certain medications. So that was like the introductory conversation at the very beginning. I talked, so he referred me to the transplant nurse. I had a very great conversation with the transplant nurse who I've seen for many years. And then I got my guidance there. So that was, there's no issues. We're gonna go forward. I see my nephrologist twice a year, and every time I would see him, he would ask me, hey, like we talked about this last time, how are things going? So he was keeping up to date on that process. And when it got to that year mark, and I don't know if it was me who brought it up or he asked, but we were at the year mark where we had been trying, we were unsuccessful. So I got brought up again, and he was very, how do I word it? He wanted a solution very quick. So the solution was, okay, given your history, I'm gonna recommend you go see the urologist. And then I got switched to the urologist, which was fantastic, which is a fantastic pathway. Talked to him, did a couple of assessments with him, and then that's kind of where we progressed to the IVF stage. But to the original question is, having your nephrologist, your healthcare providers care about you, show about that interest. It's a two-way street. We have to be comfortable talking about these things. I know, especially as men, it could be sometimes uncomfortable talking about these things, but being open, just having that communication. And on the nephrologist side is asking those questions, remembering those little tidbits that you discussed last time, just to show patients that they care. So I'll pause there.
So I just want to remind everybody, all of our viewers and those in the attendance, that if you have a question, please go to the Q&A box at the bottom of the Zoom. You can put it in there anonymously. If you don't know how to make yourself anonymous, don't worry, I won't read out your name. How's that? But we do have a couple of questions here. And I think this one is going to be for Dr. Cunningham. I'm going to call this person AA. I have no nephrologist, as I have not had active kidney disease since I was a kid. As I understand it, my condition, IgA nephropathy, is sometimes genetic, sometimes not. Is there some sort of genetic testing I can access to assess the risk of me passing it on, or another autoimmune condition? Thank you.
Yeah, that's a great question. I think there's a couple of things to touch on here. In general, IgA is not directly inherited, so there's not a genetic test for it. Sometimes there can be genetic risk factors in the way of certain people or certain families more commonly might have autoimmune conditions, but it's not like Alport disease, for instance, where there's like a defined gene that you can send a test for and see if you have it or not. So that would not really be relevant in this situation. But if you know you have IgA nephropathy and you either have heavier protein in the urine or declining kidney function, then it may be worth having a conversation with a nephrologist again, or getting a referral just to sort of discuss some of those aspects. And then in general, for patients with other genetic conditions, like Alport disease, polycystic kidney disease, et cetera, the genetic testing piece is usually accessed through the nephrologist and or medical genetics. And that can come into play for yourself and your own diagnosis, but also, as I think was touched on there by Christina, if you're considering going through IVF, there is a way to test embryos for those mutations or those genetic differences, and then implant embryos that are unaffected. So that's another way that this testing can be relevant to patients.
But then again, that's like just adding to the cost, right? It's something that people really have to budget for.
Mhm.
Because I don't,
Yeah,
I
and I
think,
mean, sorry, go ahead.
no, I was just gonna say, I think that a lot of Canadians, we're kind of used to free healthcare. So to think of having, medical bills in the tens and twenties and fifties and hundreds of thousands of dollars, I mean, it's something that people really have to budget for. And it's something that like maybe they should consider. I don't know. I don't want to
Yeah.
speak, I'm
It
not
is really
helping.
hard, and it's sometimes like prohibitive in terms of making a plan. It doesn't, it's really hard to just, I mean, unless you have some sort of massive savings account, most people can't just anticipate, like just deal with that cost as it comes. And so having a little bit of heads up ideally is helpful in trying to put money aside for that. And I would say nowadays, depending on the province, like it's not uncommon if you're paying out of pocket for one round of IVF to be 20,000. People may have some coverage for drugs and or some coverage for this cycle, depending on their extended health benefits, but it really depends on the situation. And then as was discussed, like certain provinces do have one round funded. BC is starting that in April 2025, but there can be some other issues with that. For instance, it's not immediate access. It's not as though you could do your cycle in that month. There is a wait list that gets created. And then if you don't want to wait on the wait list, you're still in a situation of paying out of pocket. And as someone who might have age as a significant factor to consider, if you're approaching 40, like waiting 2 years may actually make the difference between you getting any embryos and not. So important things to think about. But yeah, I think the sort of 100K mark that Susanna was talking about can be reached in several different ways, like through adoption, sometimes through surrogacy and that whole process, especially if multiple rounds of IVF are required. And then even just doing IVF on your own or with a partner without using a surrogate, if you're requiring something like 4 or 5 rounds to have a pregnancy, it can reach that cost as well.
I have another question here for you, doctor. It's about aspirin. This individual writes that they thought aspirin was on the no list along with other NSAIDs for CKD patients. Curious if it would be the standard treatment to help prevent preeclampsia or if other meds might be used instead.
It's a good question, and we're always happy when people have received the message to avoid NSAIDs and ibuprofen and that type of thing when they have kidney disease. But we do standardly use aspirin. This is for patients with all stages of kidney disease, dialysis, transplant, etc. It's a small dose, so generally it's 2 baby aspirin, or some centers use just 1 baby aspirin, which is 81 milligrams. And that it's usually started early in pregnancy, around 10 to 12 weeks, and continues on until about 36 weeks, so that you're not taking it anymore by the time of delivery, since it does increase bleeding risk a tiny bit. But it is the mainstay of treatment in terms of reducing the rate of preeclampsia.
Good to know. I don't know what anti-GBM disease is. I'm sorry, and I know I'm kind of putting you on the spot, doctor, but anti-GBM?
Yep, you got it right.
Okay. Oh, is that your specialty? I'm sorry.
No. Well, I did some training in glomerular diseases, but yeah, it's just a different type of GN or glomerulonephritis. Yeah.
So this individual writes in that they are 35 and diagnosed with anti-GBM disease 6 months ago, and they went through treatment which was successful. They were at 5% kidney function, and today they are at 45% kidney function. They did not end up needing dialysis. They have 1 child already and hope to have 1 more. They want to know if you know anything about anti-GBM being passed on genetically.
So similar to IgA nephropathy, it's not a genetic condition, so there wouldn't be a direct risk of passing it on to children. But I would recommend just speaking with your nephrologist, and if you haven't already, just letting them know that you're interested in growing your family, and then they might be able to give you some more specific guidance about timing and what to do with medications and how to go about that.
Okay. This is another one. I'm a 1.5-year liver and kidney transplant patient under supervision at TGH. Blood work and other tests are stable. I am 43 years old. I have a 10-year-old daughter, and I'm thinking to have 1 more child. How risk is my case with an anti-rejection therapy to have a successful and healthy baby and be well after? I don't want to speak out of turn here, but I mean, you don't really have enough of the information to be able to make a diagnosis there. Do you, doctor?
I mean, I think the main message that we want to deliver, and particularly for this case, it's a bit more complicated, would be this is probably like an hour-long conversation on its own, just to kind of start out with about risks and benefits. The one thing that I would probably highlight would be that fertility treatments and advice may definitely be relevant in this case. And so if it was something that your medical team had cleared you for, or had kind of said that they were happy with that idea from a medical perspective, then I definitely would get a fertility clinic referral sooner than later in that situation. But otherwise, it's a little hard for me to weigh in on the specifics.
You know, and this is just one question that I have, and I'm not trying to curtail the Q&As here, but you know, Susanna and Manuel and Dr. Cunningham, anybody please weigh in here. You know, how difficult is trying to manage a high-risk pregnancy while still navigating the world of CKD? What kind of strain does that put on your relationships?
I guess I'll start and then you guys jump in, but it is tough, like making that first decision too. Do I jeopardize? I waited so long for my transplant, 4.5 years. I really had to think long and hard. Am I jeopardizing my kidney? The next time if I need a kidney, am I going to ruin my chances? Like, is the healthcare team going to look at me as if I'm doing something wrong or making a wrong decision? All of those questions were in the back of my mind because I wanted to do everything right in my kidney journey. I felt like my whole journey, everything took so long, and it was just it was hard. Living with kidney disease is difficult. People refer to it as a part-time job, always you know always just it's always part of so and then once I met my husband after my transplant, you know um it's like, hi, I'm Susanna, I'm also kidney transplant recipient. Like, I felt like I had to just lay everything on him, because it's like, if you're going to leave now. So he's nice enough that he didn't run away, and he stuck with me, and then we got married, and it's like, now so I'm like, I always feel like after every little bump in the road or mountain or whatever you want to call it, I'm always warning him. And then after my transplant, or after this whole journey trying to have a child, I was like, now what? Like, are we headed for divorce? Like, what does our future look like? I didn't know what our future looked like without. We worked so hard to have a child within our years of being married. It honestly scared me. The future, like, everyone was married and having kids, and I was the only one that didn't have children. And then it's like, what does marriage look like without having children? And I always pictured having children. So I think having that conversation with him, and I think I poked him like a bear all the time, because I was like, I was being annoying, because it's just like, what do we do now? Like, those are conversations, and they're tough to have. And it's but he's still here, he's still stuck around. It's just him and myself and my dogs. And I think still to this day, it's still a hard process to understand, why me? Why can't we have children? But that doesn't deflect my happiness for all my friends having children. I think, and just to add on to that, the hardest part, if anybody's going through this, I've had friends where they're trying to protect me by not telling me they're not pregnant. And that, in the long run, that hurt me more, by that they can't tell me. And I would just be happy for them, to bring a child into this world is a blessing. So for not friends having to tell me or not include me because we don't have children is the hardest part. And that's the hard thing that I find journey not having children now. So,
You know, this conversation could go on for hours,
oh, for
and
sure.
I am so appreciative of Manuel and Susanna sharing your stories and your insights, and Dr. Amanda Cunningham, obviously your expertise and the way you're able to communicate that so easily, and using basic English that all of us non-scientists can understand. I really appreciate that. You make healthcare seem a lot easier and much more accessible when people can understand what physicians are saying, and I appreciate that. And I appreciate you and all of you for being here. I'm going to throw it back to Sadia, but again, You can find this on the Kidney Foundation's website, on their YouTube channel, if you want to go back and see some of the answers or something you may have missed from any of our presenters' presentations. Thank you so much, and over to Carrie and Sadia.
Thank you, Christina. And thank you to all the panelists for this informative and, of course, very inspiring session. The Kidney Foundation is committed to providing information and educational resources about kidneys and kidney disease. Through our regional branch offices, we offer advice and support about accessing services within the healthcare system and support in your community. We invite you to connect with us if you have further questions. We also have join us for the Kidney Foundation's Reproductive Care and Chronic Kidney Disease Support Group meetings, which are held once a month. And the next one will be on Wednesday, July the 10th from 7 to 8:30 Eastern Time. For this specific day, we're actually going to have Dr. Michelle Haludovic, Chief Medicine from Sunnybrook Health Science Center, join us as our guest speaker to talk more and elaborate more about this topic. So please join us for that session. And to register, you can always email us at peersupport@kidney.ca. Thank you, and over to Carrie.
Thank you, Sadia. Finally, the Kidney Foundation is developing a national CKD framework to transform kidney care in Canada. Our goal is to drive improvements in prevention, detection, and treatment of kidney disease. And in support of that, we'd like to invite you all to participate in a survey of people with lived experience that will help shape the framework we're developing hand in hand with all those people who are affected by kidney disease. To do the survey, you can scan the QR code that's showing on the screen right now, or click the link in the chat to open the survey. It's completely anonymous and it only takes 10 minutes to complete. You can also call 1-888-669-9691 to have a member of our team help you to complete the survey over the phone in either French or English. On behalf of the Kidney Foundation of Canada, thank you for attending today's webinar, Family Planning, Options, Lived Experiences, and Self-Care Strategies. Have a wonderful day.